Okay, I've never used Prezi before, so I don't know if this is going to click the way I want it to click. Okay, so this is, I want to stand over here, maybe. My experience through taking this medical management of the underserved and vulnerable population class. I kind of like this layout because at the bottom I kind of want to just tell a little bit about me, why I took the class, my goals, what I hope to obtain from the class, and kind of my site. And it kind of set up the foundation for, learning and growing through the entire experience. This middle portion right here with the flower pot is kind of the class itself and what we learned in the classroom. And then towards the trees is more so of my projects, what I focused on, and what I would like to reflect on in the class. So kind of why I'm here and why I decided to take the class. About me, I am from Kentucky, so I'm a huge Wildcat fan. I'm an aunt to the cutest niece ever. Her name is Collins, and then this is my fiance and my Izzy, who after taking this class I've learned that it's very important to kind of keep in mind what makes us happy and what takes us to our happy places so that we can remember that there are happy things in life, not just really sad and vulnerable populations. And that's the close-up view of them. These are my fantastic parents. They're the reason I was raised the way I was raised, of course, and care about these populations. And then these are some of the most important reasons that I decided to take this class. In the middle picture, these are all my brothers and sisters, including my two foster sisters, Jade and Alicia. They've lived with us over the past 3 years, but my family has taken in foster kids for the past 17. And what I've always loved most about children is just their innocence. They smile when they're happy and they throw fits when they're not happy. As children get older, the fits kind of change and present differently, but the concepts are the same. These kids never had that sort of innocence because they had been exposed to a lot of things that no child should ever have to see or be exposed to. They needed more than an ordinary child, and what was the most depressing is that they were least likely to get even a fraction of what an ordinary child would. They were extremely vulnerable and extremely underserved, and I couldn't help but wonder how many children live the same way, and I've sort of always had a soft spot for children as a whole. Second to my immediate family, the biggest reason, or another big reason I took this class is due to my mentors. This is John and this is Sammy. I've worked with these pharmacists for the past 8 years, and the two of them combined have taught me more about compassion and loyalty than any textbook ever could. Sammy does not discriminate. Every patient starts as a blank sheet, and their story is created through the relationship that he builds with each and every one of them. I think that we've kind of scarred him a little bit since he got here, but that's okay. John, he's one of the nicest people I've ever had the pleasure of knowing. No patient was ever too much for him. He never batted an eye about going out of his way to help those people, and his job I don't think will ever be about clocking in and clocking out. Anytime I've spent with them, I couldn't help but feel inferior to the type of people that they were. I had no idea how they could be so wonderful all the time and escape the cynical environment created in the healthcare field. So all of these factors combined have led me to take this class, and now I'd like to talk about my goals for the class itself. So as I said before, although I've been previously exposed to certain populations in my life and in retail who I believe to be underserved and vulnerable, I wanted to learn more about what it really meant to be classified as underserved and vulnerable. This included, includes like the description of the populations, what they look like, how they perceive certain issues, and what challenges certain populations face on a day-to-day basis. I also wanted to make a difference. I spent time listening to the projects the class before me had completed, and I wanted to be a part of something like that or something bigger, instead of just telling people on a regular basis what their target blood pressure goals are. Not that that's not important. Lastly, I wanted to know how I could be more of help to these populations. The patients aren't going to walk in the door with a sign on their neck that says, "I'm vulnerable and I'm underserved, you have to help me." We have to know how to identify these people and how to utilize our skills most effectively to get the most out of your one-on-one experience with those populations. So I was sent to the Allen County Health Department. Yes, I chose to go to the Allen County Health Department, which is awesome. I loved my experience. They are extremely, extremely busy. They do more than you could just ever fathom. Susie tonight, she had 4 different things that were scheduled and then canceled and then scheduled email after email about tonight, so I don't know how they do it. But this is the medical annex. This specific location is focused on refugees as well as STD clinic and immunization services. There are other locations throughout Allen County, but this is the one that I had the pleasure of working with. Their purpose is very vague, but true. They prevent disease and they promote health in the community. That's what they do. So a little bit more about who they are and what they do and how they do it. I don't know if this, okay. Kind of blurry, but that's okay. The Department of Health itself is governed by a 7-member executive board. So these members are unpaid community volunteers, and their backgrounds vary, but at least 2 of them have to be physicians. The mayor of Fort Wayne appoints 3 members, and then the others are appointed by the Allen County Board of Commissioners. The board then goes on to appoint the health commissioner and the department administrator, which are paid positions. So Deb McMahon, she's the second yellow from the top. She's the health commissioner, and that's who I had the pleasure of working with as well. The Allen County Department of Health has a budget of $4.3 million a year, and it is staffed with 70 part-time and full-time employees. They are separated into 4 major components, so the greenish boxes: administration and support divisions, environmental and enforcement divisions, clinical and case management divisions, and statistical and information support. Those departments are even further divided into the 12 divisions that carry out something called the 10 essential public health services, which is this wheel. So any health department you have a health department in any county that you're going to go in. Honestly, like, this one set the bar really high for any health department that I go in. But these are the 10 essential public health services that they should be focused on. So if there was an outbreak, for example, you would look more towards the assessment, so monitoring health, diagnosing, and investigating what exactly went on, and it kind of proceeds forward. So they do a little bit of everything, and they serve everyone. I know as far as the populations go for who they help, I mean, if you've ever stepped foot into a restaurant or swim in a community pool, that's what they do. I mean, they made it safe for you to do that. I got to see just a wide array of populations. My first day there, an elderly couple walked in, and they were for immunizations to travel, and they were complaining because there weren't enough lines on the paper to say all the countries that they had been to. I was like, that makes me feel vulnerable because, I haven't been to that many countries. But but then again, as I said before, the site was a large center for refugee services, so that was very interesting. They are responsible for investigating, monitoring, preventing, and treating communicable diseases. This includes STDs, insects and animal-borne diseases, food and waterborne illnesses, and childhood lead poisoning. They also review, license, and inspect retail food establishments, tattoo and body piercing establishments, hotels and motels, sewage disposal systems, public and semi-public pools, and also railroad camp car systems, which is strange. They collect, preserve, and issue birth and death records and affidavits for paternity. They also provide child and adult immunizations, health screenings for refugees, case management for lead-poisoned children, confidential STD and HIV testing and counseling, TB testing, and then communicable disease investigations and foreign travel consultations. So essentially, the health department sees everyone in the community. I don't feel as if they get enough recognition for all the things that they're responsible for. When considering the population that actually utilizes these resources, I've always thought of more vulnerable populations. You only go to the health department if you don't have a real doctor. When the physicians here are more than highly qualified to take care of anybody that walks in the door, and they're going to do it with more compassion than a lot of the doctors that I've seen. Even though they do have the budget, the $4.3 million budget that they do, and 70 employees, there are so many things that they want to do that they just don't have the manpower to do it. Otherwise, I really think that they would do it all. So something as simple as not having a family physician, it does make a patient more vulnerable because they're responsible for their health, their records, their past medical history, and medical stuff, as we know, is very challenging. I'm very well aware of what vaccinations are necessary, but when I go to upload those on our portfolio, it takes me a long time to figure out what I'm uploading, where it came from, and to know what I'm doing, and I would like to think that I'm pretty well educated. So, refugees, as I mentioned, a time or two, are a huge population that utilize these services. They essentially come to the United States and they have to do everything that someone is telling them to do. And they're scared. I mean, in addition to coming from somewhere that may be very violent or, somewhere very scary, it's also scary to get away from that and to come to somewhere where you have no idea what you're doing. You may not speak the language. You're just trying to do everything right. And believe it or not, they're required to meet certain requirements that even United States citizens may not meet. So they're required to undergo certain testings, certain screenings. Imagine coming here not really speaking English and then going to an STD clinic and they're going to screen you for everything. So I imagine it's, very, very challenging. So in addition to picking this site for the class itself is what I think I took away most from my experience, and before we'll move on to the projects themselves. So in the classroom, I was surrounded by a lot of my peers who had a variety of reasons for taking the class, as well as a variety of goals of what they hoped to attain. We were all very similar yet very different in our ways, and through topic discussion it was interesting to see the different viewpoints we all had depending on our background, and it was nice to get other mindsets about similar ideas. The professors, Dr. A and Dr. Hansen, are in large part why I took away so much from the classroom, and I would say that even if they weren't in this classroom. I've never felt poorly about expressing my opinion about anything with them around. I think that was a lot of the reason why the first 10 minutes of every class I felt like it was a therapy session for me to complain about my first world problems and not feel like a turtle jerk, because I didn't think they were going to judge me for anything I said. They provided first-hand experience when they discussed certain topics and really brought the patients to life. So the most important people in the classroom, and that was the patients. We talked about these patients as people. When they were brought up, I had no idea what their latest lab values were or what they presented with their chief complaint. I came to know them more as human beings. The principles. So in class, I always ask myself, why do I care about this? For certain diseases, it isn't the uniqueness of the topic that draws me in. It's more of the application it has for my future. When we talk about diabetes or blood pressure, I'm like, I should probably understand this because I'm going to utilize it a whole lot. No offense to Dr. Town, but sometimes I catch myself thinking that it's very unlikely that I ever encounter somebody with an infection that's resistant to every bug we've ever learned about, and they can't take any of the drugs that we normally use. But more so, I feel like I'm playing a very large game of memory and just trying to get through. The principles laid out to me in the classroom made me care because of the prevalence. There was such a variety of things that I had never considered that played a role in health disparities for this population, such as, genetics, their social environment, stress factors, their socioeconomic status, and their physical access to health care. The class laid out the principles I needed to develop a social consciousness of the world that was around me. And of course, the practice was always also discussed. It wasn't as simple as certain populations do not trust today's healthcare, so you need to build a relationship with them. It was the practice of creating a better world for these populations. So it wasn't the interaction that you had to make with the patient. It was about, talking to other physicians about why that interaction was important, or advocating, the care for this patient population. And that wasn't something I had considered prior to this. During the second week of class, I had the opportunity to step up and do what I believe was right for a vulnerable population, even if it ticked off my superior. While I don't believe he'll change his ways anytime in the near future, his reaction at the very least showed that he noticed my actions, and hopefully it'll make him think twice about his actions in the future. And lastly, we talked about specific populations and the key concepts that related strictly to their population compared to others. And this spanned from talking about those who entering the world from incarceration or homeless to even those seeking refuge in the United States. So taking away kind of my foundation and what I was learning in the classroom, I had the opportunity to be a part of a couple of really cool projects. So the first one was our hepatitis patient assistance project. 4.4 million people in the United States have viral hepatitis. As of 2013, approximately 7,500 people were reported to have hepatitis in the state of Indiana, so it is a local problem. Hepatitis treatment can be very, very expensive. Over the past couple years, however, the treatment of hepatitis C has become a lot easier. A patient can now take a single pill once a day for 8 to 24 weeks. so 28 pills per month, compared to the 280 pills per month as seen with drugs such as the Vicura pack that was once promoted for hepatitis C. And it's made by the same company, so they're both great drugs. This is great, but it is very, very expensive. The simpler hepatitis C regimen, where you take 1 pill a day, it's about $1,000 a pill. So it is a cure, but it comes at a very, very high cost. In the state of Indiana, 17% of the population has Medicaid, while 11% are uninsured. So Medicaid does cover hepatitis C treatment, but you have to meet certain criteria, and long story short, you have to be really, really, really sick for them to pay for your hepatitis C treatment. It's kind of what it looked like to me. So, your lab values had to be this far out. You had to be entering cirrhosis. And that doesn't make sense, because to me, I'm all about preventative care. Why can't we help them when they're pretty healthy? But that wasn't the project. And then 11% are uninsured completely. And these patients, they don't qualify for Medicaid, but if they paid for insurance, it would probably put them in underneath the line for Medicaid. So I imagine that's challenging too. For whatever reason, they decide to not be insured. So day after day, the health department encountered patients who were clueless about their current health status. They were the first ones, and I got to sit with a woman named, Linda, and that was what we did all day. She called people and told them that they had hepatitis C, or that their results came back and they had, XYZ STD and they needed to come back. And these patients had no idea. I remember there was a 41-year-old, and she was going through the risk factors, and this lady was just like, no. She had never, she didn't meet the list. She had no idea how she had contracted it, and she was in the chronic state. So in addition to telling someone they have hepatitis C, you have this really good news that there's a cure, but then you need to tell them that, we need your firstborn child to help you, because it's so expensive. So they didn't know what to do. So I wasn't involved in this project as much as I would have liked to have been. There was lots and lots of meetings that were during the day, and I had to be here. First, I created a brochure about hepatitis C, because she showed me the folder that they hand to these patients. And the information was just all over the place. It was pretty much a folder that Gilead had put together. And Gilead is the makers of the hepatitis C treatment that the patients would more than likely receive. And it was very hard to read. There was just a lot of numbers and a lot of statistics, and it was just kind of all over the place. So the brochure that I helped put together for them, it's very, very, it's in layman's terms. It's just very simple. This is what hepatitis C is. These are some of the risk factors, and it kind of has a, where do you go from here? And so it's just got, if you have Medicaid, this is kind of what you need to do. If you have private insurance, so on and so forth. So that kind of gives them a simple thing that they can read and, understand everything. But one of the biggest issues they had is Deb McMahon, which is the health commissioner at the health department. She does not have the time whatsoever to be the primary care provider for these hepatitis C patients. I think as much as she would like to, it just can't happen. So, they would see these patients, they would do their labs and everything, and then they would say, okay, well, this is, you need treatment. So what we did, and to help them get their treatment paid for, was we set up, we have 2 case managers now from Gilead, and they're actually out of Nashville. So Gilead flies them up here once a month, and they are going to be the Allen County Health Department's case managers for those patients. So they are just a one-on-one liaison, walking the patients through the process, what they need to do, what information they need, and getting them on the right track. So it's not, holding their hand through the entire process, because they do have to get a prescriber on board. And so they're still looking into that to see who exactly is accepting patients, without insurance or with Medicaid, and what they can do. So that was really cool. I didn't realize, you learn about it in class, and they give you all these numbers and the little colored people to show you how prevalent it is, but you don't really know how prevalent it is until you go somewhere where that's what they're dealing with every single day. It seems like it's just a much bigger deal. The second project that I'm still currently working on with the health department is related to naloxone accessibility. For those of you who don't know, naloxone is a drug that can be used to save people's lives from opioid or heroin overdose. So the receptors that the drug binds to that makes a person happy Narcan or naloxone, that is the generic, it goes in there and it blocks those receptors so that no more drug can bind. And ultimately, most people that overdose with heroin or opiates, they end up deceased because their breathing stops. So if you get to these people within a certain window, you can block those receptors and potentially save their life. In April of 2015, so just this year, Aaron's Law was passed, and what this law did for Indiana was it allows for a layperson, so you or I or anybody, to carry Narcan. And you do still have to get a prescription for it so that you can obtain it, but it allows the physician to write a prescription for somebody that it's not directly for them, and that's a big deal because that's kind of how a prescription works. You go to the doctor, they write it for you, you take it, and you're good to go, but the physician can knowingly write this prescription and it be for someone else. So the biggest, what it really did for us here in Allen County was firefighters and first response personnel begin to carry Narcan, and the first response personnel have always carried, I learned, intravenous Narcan. So, they're trained and they could do that once the adult or child was in the ambulance, but this Narcan is just intranasal. So it's very, very easy to use, it's cheap compared to the intravenous, and it's very easy to use, like I said. So the firefighters were actually recognized on the news this morning, which was pretty cool. And since from August 10th until October 31st, the Fort Wayne Fire Department has saved 16 lives. So it's been a really big deal, and it's really neat. From 2003 to 2013, according to the CDC, heroin and opioid-related deaths have moved from 3 to 152 in the state of Indiana. So again, it's a big problem. And then I have on here that a stupid choice doesn't have to be a person's last choice, because there's a lot of mixed feelings about this. Like you can't just pass out Narcan like candy, because then people are going to shoot up more. You take away the risk of using drugs when everybody has their own opinions about those kind of things. But to me, everybody deserves a second chance to clean up their life, to get better. And the patients that are using these drugs, their life is more than just their life. They may be a mom. They may, of course, have a mom, have a dad, have siblings, people whose, their lives are affected by the situation too. So kind of what I have in mind and what we're working on is to be able to, if I was an interested party, to go to the health department and say, I have a sibling who I'm really worried about. I've learned about Narcan. Is there any way that you could give that to me? That way, if I ever found him or her, I could do something. So I wouldn't imagine this as being similar to purchasing Tylenol, but ideally it would involve like a short education segment on addiction and withdrawal. And after you give the patient Narcan, it is going to be a long road, because some studies have shown that after patients use Narcan, they hurry up and use the drug again because the withdrawal effects are so terrible. And then other studies have even shown that patients who receive Narcan are twice as likely to die with like a similar or lower doses of the opioid or heroin, which is scary. So there's a lot to it. So I would like there to be more education on the matter. So as a stepping stone to this, Dr. McMahon and I got to talking about it, and she said, well, we can start with small steps. So what we'll do now is, I would like to start with physician referrals, only focusing on accidental overdoses, like with elderly populations or populations who are chronically prescribed opioids. So in the state of Indiana, last year alone, it was in Allen County, 11, but it's still 11. There were 11 related deaths of individuals over the age of 50 who died from an accidental overdose from their opioids, and they were drugs that they were prescribed to control their pain. So she said, well, we'll start with that. We'll take referrals from physicians. So those patients can come here and receive their Narcan, and they'll receive like a little bit of training on what it is and how it works, and that'll be a step in the right directions towards getting it into other people's hands. But instead of just sending out an email to prescribers saying, hey, you can do this, we want to gauge how the community feels about doing something like that. So what I'm working on is a survey that's going to be sent to healthcare professionals in the area, gauging their thoughts towards the use of Narcan. So these questions measure such aspects such as their belief that heroin or legal opioid use exists, their comfortability prescribing naloxone to a patient or to a third party, and even their thoughts towards the needle exchange program, which is also a really big deal in Allen County right now as well. And I've never thought about it, but it's nice to have help on your side when you're trying to change something. So, if you look out and you get how everybody feels about something that you're trying to do and get them on board with what you're trying to do, it's going to be a lot easier to get that done than you just trying to set out and change the world overnight. So kind of my reflection, looking back, I think the biggest thing that I took away from this class is just my perspective. And I kind of think about it as in, so in class, you learn different factors about a disease, and at the end of the day, they're hoping that you can look at a patient and apply all of those factors and treat the patient. So, such as diabetes. So if you were considering a patient with diabetes, you would want to know a little bit more about the patient so that you can pick appropriate treatment. So you need to we learn the parameters, the caveats to treatment, and then most of those rely upon organ function, drug-drug interactions, and everything. So this class, it taught me to perceive, it's really red, it taught me to perceive a patient as a person, not as a patient, not as a disease, not as numbers or complications, but someone that I genuinely care about. So I think the power of perspective is underplayed. The brilliance of perspective is once you learn how to control it, your cognitive abilities are just endless. I can help any patient that approaches me. I may not be able to change their outlook on life or give them everything they need when they walk out of the pharmacy, but I have the ability to do more for them than absolutely nothing. And if I can't, I think that this class has given me the confidence to try. And that's all.
All right. I just want to start off by saying thank you to Dr. Hansen and Dr. A. I have enjoyed this class, no offense, more so than any of the other classes that I've had thus far. It's been a pleasure to reflect on why we wanted to get into pharmacy school in the first place, and I think that's kind of the reason that a lot of us came to this class, and I'll talk about that a little bit more in a second. Also wanted to thank my preceptor, Dr. Armina, and Matthew 25 community who welcomed us in so much and wanted to help us any way that they could. Our outline is we're going to tell you about kind of why we wanted to take this class a little bit more in depth, then about Matthew 25 and their patient population, and then we're going to talk about us trying to get into some projects. We looked through several projects and tried to get involved with many of them. We're going to talk about the strengths we had in doing that and the weaknesses we came across, and also how you can help in the community through Matthew 25, and then we'll reflect upon what we've learned from this class. So the reason why I have gone into two different things at this school is from our keynote speeches, and I also got involved with Kidney Camp through listening to a keynote speech the year before my freshman year, or the P1 year, and then the P2 year I got to hear a keynote speak on this class. And what I found most was that I was in admiration of the students that were before me. That one, I looked at myself and I said, well, why can't I do that, or why am I not doing these things? These are the things that I want to do. And in reflecting upon that, internally I would say to myself, I didn't think that I could do that, or I didn't think I was prepared to do that yet. I'm not far enough in my career and my knowledge to be able to provide that kind of service to somebody else. Like, those are for adults and people who are already pharmacists. Like, they do those kind of things. That's not for me. I'll do that after I graduate. But like with this class, the way that they displayed this class was like, this is what you need to be doing in every one of the experiences you have. You need to reflect upon the things that you're doing, what your goals are for the future. And I mentioned this in one of our classes, but I'm the kind of person that already reflects on things. I'm emotional for a guy, and I'm very analytical, so I think about the processes and things that I'm doing. But I didn't realize how little I do reflect once I got into this class, and doing that as a scheduled activity, it's been so beneficial to where I want to go and what I want to do with my career for the future. The desiring to use knowledge and the desiring to gain knowledge, that kind of ties into me saying, now that I realize that I do have something to give, I'm not completely useless. I do have something to give already, even though I'm only in my third year of school, and saying, how can I use that? I don't really know. I don't really know what I have the potential to do. And so entering this class, I was like, this is what I'm going to see. This is what these kids who were in the year before me showed how much they could do. It was so amazing, and I was like, I want to be able to do that. I have the desire to serve, but I don't know exactly how to do it yet. And so to lead me into talking about Matthew 25 a little bit more, this is kind of what the organization is based off, and that's Matthew 25, a passage from the Bible. For I was hungry, and you gave me something to eat. I was thirsty, and you gave me something to drink. I was a stranger, and you invited me in. I needed clothes, and you clothed me. I was sick, and you looked after me. I was in prison, and you came to visit me. I tell you the truth, whatever you did for one of the least of these brothers of mine, you did for me. And I got the pleasure of working at Matthew 25 after, this is, that's exactly summed up kind of why I wanted to take the class in the first place. So Matthew 25 was started by Father Tom O'Connor. Right on the paper. I get off my notes fairly easy when I start to talk. So it was started in 1976 by Father Tom O'Connor, who was working with just a prayer group, and they were inspired by this passage through Matthew 25 and said, we need to be doing something. Kind of the same reflection that I had after seeing the keynote speech is we need to be doing something, not just just speaking these words or thinking that you're doing things. So it started up then, and based on the needs of the community and really reflecting upon the underserved population in the area, the Matthew 25 has grown very quickly. And what's amazing is it's all through the support and generosity of different local foundations, grants, and volunteers. So as of now, Matthew 25 is it is the only organization in Allen County who is serving is fully non-for-profit, serving for medical, dental, and vision all under one roof. And the mission of Matthew 25 is that we are inspired by the gospel to provide free primary health care services to uninsured, low-income residents in Allen County.
So I wanted to kind of touch base on the type of populations that Matthew 25 deals with, and this is by no means exclusive, but this is my reason that I wanted to take this class specifically is because I'm interested in senior care, and so I wanted to be able to learn more about their struggles navigating the health system, and hopefully being able to, in the future, be an advocate, because like Matt, I kind of had that same perception of I'm not ready to really help yet because I'm not done. But that's just not the case. So this was just something that I came across when I was putting the presentation together, that almost 1 in 3 working U.S. families struggle to meet basic needs. And we played a game in class, and it was fun, and we giggled, where we had to basically allocate our resources towards our basic needs, and then an event happens, and some of those have to be taken away, and that means that something else is suffering. There was not a way to make every end meet. So I thought that was a good quote for that. Wrong way. So the working poor, the census defines the working poor as people who have worked but who nonetheless fell under the official definition of poverty. And that, depending on what area of the country you're in, can be a relatively large population. I mean, I'm sure everybody's heard the new debate on, raising the minimum wage and fast food workers wanting to raise it up to $15. Well, that would be great, but it's not likely that's going to happen, so we still have this pretty large segment of the population that are working hard and either are uninsured, underinsured, or just aren't able to make ends meet. And these are some of the faces of the working poor, and when you think of the working poor, you may think, someone that's, down on their luck, they can't do any better, they're not educated, and that's not necessarily the case. Went the wrong way. So what we really want you to think about is the uninsured. Why are they uninsured? They may be refugees from another country. They may be single parents making ends meet. They may be recently homeless due to a disaster. They may be single parents that just are trying to scrape together their basic needs. So we've got seniors, single working families, low-income families. And then when we're talking about homelessness, most of us, I'm sure, aside from us in our class, when you think homeless, you think of what everyone else thinks of, under the bridge homeless, and that's not the case. There's several different types of homeless. There's short-term, long-term, and chronic. And unfortunately, due to just the exposure in the media and just what we see the chronically homeless. We see them on the side of the road. We see them under bridges. We see them under all these stereotypes. But the fact is that a lot of times, someone can have a fire in their home. They're homeless. Just because they're not sleeping on the street doesn't mean they're not homeless. They may rely on friends and family to get by and transition. They may or may not have that support system, so they may find themselves in shelters. And these are some of the population that Matthew 25 does deal with because they're not able to make ends meet with their health care costs. I've got to stop going backwards.
So the first thing we did when we got to Matthew 25 was kind of say, well, what can we work on here? What's our projects going to be? And after looking how the organization started and the steps they've taken to improve upon the needs of the community, we started to look in what has changed. What has changed recently, a really big thing, is the implementation of the ACA. And it's a great thing to be able to provide insurance at an affordable cost to patients, but how can that affect patients in a negative way? Matthew 25 provides very amazing health care to patients who are completely uninsured, not on Medicaid, not on Medicare. And so now that there is a sort of a requirement to get your own health insurance, the patient has to say, do I want to get a minimum health care health insurance and pay a certain amount of money when I can be getting maybe better care at Matthew 25 for free as long as I don't have health insurance? That's something that maybe not everybody reflects upon with an organization that's serving people who have zero health insurance. And same thing goes for, especially for people we were talking about that have hepatitis C. Are they going to be able to get covered through a minimum, one of these ACA health insurances through that? Maybe not, but through Matthew 25 and different PAP programs, they're able to provide different things like that. So another thing is since the implementation of the ACA, there's been less funding. There has been less PAP programs because the insurance companies the manufacturers do see that there's coverage now, so they can get money from health insurances, so they're not providing as many PAPs. Things are going, or drugs that have been out for a while that originally had patient assistance programs, and I don't know, I feel like everybody here probably knows what a patient assistance program is, but I didn't know anything about it when I first got into Matthew 25. I really didn't. I knew that there was things out there to provide. I knew that if a patient came into the pharmacy, I would say, look online at the manufacturers. They can help you out. And that's about the gist of it. But it's another wonderful thing that I've kind of been asked to look into through working with this organization was, how do you get that? I didn't know. Misty will talk a lot more about that because it's kind of one of the projects she was working on. So I'm going to get to the projects that we worked on right after this slide, but this is kind of the process that we got through when we got to Matthew 25. This was our headquarters. This was the desk that we worked at upstairs in Matthew 25, and 2 hours is really not a lot of time each week to be able to work on these things. So we were there for 2 hours each week on Monday, and we would kind of go through, what are we going to do next? What are we going to be doing over the week? And what kind of information and service things do we need from Matthew 25 so that we can go further look into PAP programs or look into the service projects that we're into. This is Ermina, who's sitting here, so I didn't really have to put a picture up to her. But so we looked to her for guidance. What needs to be done? She is the development director. So she basically is able to keep this non-profit organization afloat by searching out different funding and the needs of the organization, which is just amazing to me because I wouldn't know the first thing to do to keep such a giving organization afloat. And so we also went down to the medication room. This is the pharmacy, and to see what their needs were, what kind of challenges they were facing. And that is kind of led by Liz, who is the head technician down there. She was able to give us a lot of information about the challenges of having a kind of a not so great computer program to track imagery. I don't really know what word I was looking for there, but there's yeah. It's very difficult they don't have the money to have a lot of the computer programming that Kroger or Walmart or most of your retail pharmacies would have to do a lot of tracking and ordering of prescriptions. So they have to do a lot of work to be able to implement different orders that are being sent from the physician into the computer system, be able to track drug interactions and refills and implementing PAP programs. And the work that they do there is another thing. If you want to get involved with doing a volunteer program or volunteer work with them, it would take a lot of time to get involved to be able to do what they do right now. It's amazing what they do with how little that they have. This is Samantha. So she is kind of new to the position that she's working in, and she does Liz will assess the needs of the pharmacy based on looking at the shelves to say, what are we running out of? That's their inventory. And she will make an order list, send this up to Samantha. Samantha goes through McKesson, Anda, and who was it? Henry Schein. And she'll go through and basically try to find the best prices to save money on prescriptions and supplies. And this is Nikki, and she's in charge of doing the PAP program. So Liz, again, will assess is there PAP programs available for things when she's getting orders from the physician. If there is one or they need one, it will be sent up to Nikki to see if she can get the paperwork all started for the patients. And here's Dr. Sister and Dr. McCafferty, who, again, are probably some of the busiest people that I've met doing volunteer work. Not getting paid the big bucks to do what they're doing and doing something, doing service that is just so much. Gosh, I just am out of words right now. They're doing so much with so little, and they do so much more than a 15-minute counseling session with a patient. Dr. McCafferty's meeting with patients to talk to them for as much time as they need about their diabetic medication supplies. And every time I go to meet with one of them, they're busy doing something. They're always with patients. They're always working, even after hours, after they're done with their normal day. So here's some of the projects we were working on. As soon as we got there, we really...
So many dinners during the week.
The first thing we looked into is patient assistance programs. How can we get more of them? If we need more of them, is the process very efficient? Can we make it better? It takes about 4 to 6 weeks to get a person in patient assistance program. If it's 6 weeks, you're going to have to provide medication to a patient for 4 weeks, and maybe another 2 weeks before you're getting that medication in from a manufacturer, and that's a lot of money for the pharmacy. And with having limited funds, that's a really important thing to be looking at. We also looked into AmeriCares and Direct Relief, which are foundations that donate medications to underserved populations or for relief programs in emergency situations. We looked into that before really realizing that these things are already being implemented. And this was one of the challenges that we found getting involved with a volunteer organization. There's a lot of parts moving around, and there's people that aren't there all the time. So it's sometimes hard to figure out what needs to be done, what's already been tried, and where to move forward. We also looked into 340B, and we found out also that we are not able to qualify for that, being only serving the Allen County population. And even though it is funded through the United States government, would we be able to take that not through the government?
They can't take
Yes, I know we can't take it. I think it's because we didn't serve outside the Allen County. You have to take Medicaid as well. Okay. So we can't do that as a not-for-profit organization. So another thing that we looked into was Script, which I heard up through the church that I go to, and this is kind of like a program that they have involved with Kroger, where a portion of the money that you spend is given back. I'm going to go into more. I'm so sorry. It's one of the projects that I finally were able to get into. We also wanted to look into patient counseling room because there's going to be an expansion, hopefully in the near future, and so we wanted to know what the needs of this patient counseling room would be for the population. We looked into updating the formulary, and that's where I'm going to get back into kind of the computer program that we have there. Epic's going to be implemented from Parkview very soon, and actually starting in early November, they had people coming out to start implementing that into the pharmacy. And so there was really no point of us in redoing a formulary and looking into a formulary when they're already going to be kind of going through and adding that into a computer system. We're working on that with P4 students right now for Manchester. We also were going to look into updating the substitution list and kind of combining that with the formulary and with the potential for $10 and free medication list from local pharmacies. And this would just be so that all in one place you would be able to look and say, how can we get the most affordable medications to our patients, and based on what we had in inventory and what was available to us, what we could give to our patients at the time. Lastly, in the last week, we got some information from Dr. McCafferty as far as looking into our previous inventory and ordering. So we got some purchasing orders from all the different Anda and McKesson, and finding out what we have, what we are using currently, and then what we're going to be using in the future with the implementing of Epic. So these are the three things that we are actually able to start to get into process, and we'll go into more detail right now. The med list it's fairly simple. I went and they the technicians downstairs kind of already know this information off the top of their head, but to know in the local area what pharmacies provide free medications, $4 medications, and $10 medications. The real important one is to know what free medications are available. Even $4 and $10 medications can be difficult for a patient to afford, especially when you're taking 7 to 10 medications. That's still too much, and that's still going to affect compliance, and that's still not good enough for the patients there. So I went in and talked to each one of the different local pharmacies and the independent pharmacies, and these were the only 4 pharmacies that had something that would actually be beneficial to our patients. So I created an Excel file, basically, which we want to add with the substitution list, so that upon looking at what you're going to be changing to, you can say, well, if we don't have it in stock, this pharmacy, you can send this patient to this pharmacy for free medications. You can send it, and if we don't, if it's on the free list, you can send them to get $4 medications at a Meijer or a Kroger or a Walmart. The Script program was started in Michigan. And this program is basically working with 300 to 400 different merchants, and they sell gift cards at a discounted price to this organization. So say you buy a $25 gift card and they'll give it to you for $20. So you're able to sell that to whatever population you're working with and get a percentage back for your organization. So as you're shopping, you're using $25 at Little Caesars anyways every week or whatever. You might as well be saving or giving money back to a foundation of your choosing. Unfortunately, with the small population at Matthew 25, I found it difficult to be able to implement this organization into Matthew 25. Who was going to be purchasing these gift cards? Was it going to be the employees? If so, I think that the employees would, because of their service orientation and being volunteers, they'd probably be willing to give whatever percentage was right back to Matthew 25, which would be awesome. But with a small population, how much money is that actually going to be in the time it's going to take to get the involvement with the Script, which means you have to order a bunch of gift cards in, have an inventory of them, it's really not going to work out. Secondly, I thought, would patients want to be purchasing something to this? Would they want to be giving back to the foundation that works for them? They're still working on limited budgets. They're going to be able to plan ahead to be able to have money for the week to purchase gift cards that they're not going to maybe use for a month or so. Are they going to want to work on something like that? So after going to talk with the two people that work on that at my church, they gave me a phone number to the vice president of Great Lakes Scripts. And he is one of the nicest guys I've ever talked to. He's like, we could meet up. We could meet up and talk about this, because he and this organization are so focused on just getting funds to different organizations. And so right now he's working on possibly being able to get, instead of having like a rebate basically on percents that you're going to get back from these gift cards, to say, could we sell, if we are getting 5% back on a gas gift card, could we sell it to a $20 gift card to a patient for $18 and help them to save on their gas, their gas for the week, and then 2% go to the organization, 2% is going to be what's saved for the patient. So they're working on that right now, and that's something that I'm planning on working on even after this class, to finally get that implemented in whatever way possible.
So everybody does know what a patient assistance program is, PAP. Anybody have to apply for one or work through someone going through one? One person. So you know how long it is, how much paperwork it is, how much back and forth it is. I have a very good friend with Crohn's disease, and he was prescribed Humira, has great insurance, better insurance than I've ever had in my life. His copay was still $1,500. And he makes a decent living. So we basically work together to get him on the patient assistance for Humira. So it's not even necessarily just your very low-income patients. So that was something to keep in mind in our future practice, that you may have someone that has a drug that they require, and they may not be a vulnerable or underserved population, but you can still have these resources to help them. So as Matt mentioned, one of the projects that we wanted to be able to present was making the patient assistant program process easier. We're literally talking about physically separated locations from downstairs to upstairs, and then we're also talking about, separate entities doing separate things and then coming together to get these PAPs for these patients. And as Matt mentioned, it can take 4, 6, 8 weeks. And in the meantime, these patients are still being provided their medications at no cost. So what we did is we basically went to all of the drug manufacturers that we had, as you see here, and then some, to do two things. We wanted to be able to create a usable document. So it's an Excel document that lists all of the patient-assisted programs that are available from all of the manufacturers, which was helpful because a pretty good number of patient-assisted programs were discontinued with the Affordable Care Act. So we needed to know what drugs were no longer available through a PAP. But I also found quite a few that were now available. The caveat with that is that a lot of them are, not necessarily common everyday drugs. They may be treating, unusual conditions, but they were things that we included because you never know. You might have that one patient that comes in and needs this one strange medication that none of us are especially familiar with, and then you find out, hey, there's a PAP for that. So let's go with that. So we've got an Excel file that's got basically, your kind of short reference of what the manufacturer is, what the drug is, and then where you can find the application. But we wanted to do a little bit better than that, since they are in the middle of transitioning, getting into Epic, and they are communicating, between upstairs and downstairs, between the medication room, the doctors, the pharmacists. We also put together a binder of the actual materials. So you would have kind of a table of contents. Here's your drugs. It's in alphabetical order. Here's your application. Pull it out. Make a copy. Go for it. So we're trying to place those in. I'd like to get 2 copies, to place one in the pharmacy or in the medication room, and then place one upstairs with Mickey, who takes care of the PAPs. So everybody's on the same page instead of kind of wondering, well, I thought you were looking. Is there one? Isn't there one? We wanted to have something concrete and then something that could be editable in the future with the Excel file to say, here's what we have. Now, of course, things are going to change, and someone's going to have to still be in charge of maintaining that to see if there's some that have come, some that have gone. But I feel like what we put together was something that was going to be useful right now. So that's what we basically came up with for the bigger project of the semester. We are still going to look into the ordering and inventory analysis. I know Matt mentioned that he wanted to continue to volunteer at Matthew 25, and I did as well. So that may be something that we work on in the future. And if anyone else needs to get some service hours in and is really good with numbers, give us a call. So what's the impact of these projects? I know that I wasn't the only one that came into the class thinking we were going to be working with patients. We didn't work with patients. Did we have an impact? I said going into the class. So did we have an impact? Of course we have an impact. You know, it's the ripple effect. Every little bit counts. So the fact that we maybe helped streamline a process to where a patient can get their medication paid for 1 week earlier, because now it's not so much shuffling paper and you know, trying to communicate between, you know, two different places. That's 1 week of X amount of dollars that Matthew 25 is able to save because they've gotten that process quicker, smoother, and they're getting the medication in on a regular basis. So we, of course, one of our main goals was to save money. I wish I knew a better way to just reach out and find more money in the ether, but hopefully with this we are going to be able to save them money by getting it done quicker and faster. Be able to supply more medications. So with some of these PAPs that we weren't available, that we were not aware were available, that we now are available, we may be able to look at and then say, well, we can use this instead of this, and also then have the API students that are working on the formulary and substitution list be able to see, well, these are also available, so let's take a look at where we can save money with these. And then, of course, the smooth workflow going between, you know, upstairs and downstairs and between the patients and the employees. And we want to save time, and time is money, and so the quicker we can get those medications, especially when they're free, the better for everybody. I lost my thing. So challenges, we did have a few. As Matt mentioned, it is a volunteer organization. There are some paid employees, but for the most part, it's a matter of coordinating between, you know, a number of different people, a number of different places. And these people, a lot of times, you know, are also working, are students just like we are. And that can be a challenge to try and get everyone on the same page all the time, every day, especially when you're only seeing someone like us once a week. The technology, as was mentioned, they're just now implementing Epic, so that's a big one. You know, we take that for granted, that you could just go, well, what did we spend on medication last week? Well, let's just look it up. Well, that's not a thing. We're going to do that by manually looking at everything. You can't just say, you know, well, the patient needs this, and it's going to be this price today, and then you go to order it the next week, and it's jumped up in price, and so they've got someone that's every week looking at where's the cheapest place to get the medication. And then again, the coordination efforts. It can be challenging to, you know, for us to communicate with our lives, with our, you know, work and school, especially with the volunteers and everyone that's very busy at Matthew 25. So it can be a little challenging to, you know, get everyone on an email or to get a meeting. And it's just because there's so much that needs to be done. And that's why we had such a large list of potential projects, is because there is so much that can be done. There's no way that Matt or I would ever be able to do it. But there is the need. You just need to look for it and then see if there's something that you can do. So what can you do? We're going to try and recruit you to volunteer. It was a pretty cool experience. I personally had never dealt with a nonprofit organization. I had never had a long-term volunteer experience. So it was rewarding in that way that, you know, every week I was working on something that I hope was going to impact long after I'm gone. Of course, you can always donate. You know, donate your time. If you can donate monetary, money is always welcome. Or if you have any sort of suggestions or great ideas as to how we could potentially get more money into Matthew 25, we would be more than willing to hear what those ideas would be. And then script, if Matt's able to get that implemented, it would be a matter of spending the money that you would spend already on things like food and gas, but then having that percentage going back into Matthew 25. So in terms of what we learned in the class and for our last class, we all left kind of a last note, and my note was that I thought the class should be mandatory. There's a class we're taking this semester that will go unnamed that I don't feel we're getting a lot out of. However, I felt like I got so much out of this class. You know, I mentioned that my main goal was to learn more about, you know, the challenges that seniors faced, and I wasn't really thinking about all of those other vulnerable populations because that wasn't really my mindset. So it was very eye-opening. And part of that is that we had within our class a judgment-free zone, so we could get a little heated, we could get a little excited, we could get a little silly, and there was never any issues with that. And so I know that we're going to walk away, having taken this class, trying to create that same judgment-free zone in our practice in the future, because we want to basically be able to communicate with our patients. We want them to communicate with us. And something that we touched on one of the earlier weeks was creating a therapeutic alliance, which is basically developing that trust with your patients so that they will want to be open with you and be honest with you, that they'll want to share with you. Because some of these populations, for whatever reason, they don't trust healthcare, they don't seek healthcare, it's an uncomfortable situation, it's awkward, it's difficult. And so it might take several visits to kind of build that therapeutic alliance and draw them in. And it's going to be an effort. It's not necessarily something that's going to happen very easily. So it's something that you should be aware of so that you can put forth that extra effort. And of course, with Dr. Hansen and her motivational interviewing, that's how you draw them in. I mean, they're not going to necessarily walk in and put it all on the table for them. You've got to be able to build that trust by drawing it out. And you may have to draw it out over time, over weeks, over several visits, over several months, but you can't give up. And of course, just listen. Let your patients talk. Sometimes some of these people, you know, be it if they're mental health patients, if they're homeless, if they're just having a struggling time in their life, they may start to feel as though they're not being heard. So give your patients a chance to communicate with you so that you are able to then create that trust with them and truly listen to them and not just write down the important facts and the important numbers, the important lab values. You really want to be able to listen to your patients. Empathy, of course, is a big one. I think that was something that we had to really think about every week in class. You had to put yourself in the other person's position. For example, I would have never thought that I was responsible as a pharmacist for showing empathy to someone who was just released from prison that required care. I would have never thought it. It just wasn't something that ever came to mind. Whereas now I'm thinking, I don't know your story. That's not my job. I need to still be able to care for you, and I still need to be able to build that trust and build that therapeutic alliance. Of course, that was the biggest thing that I took away from the class was empathy and, of course, understanding. So my reflection, I definitely got a lot more out of the class than I expected, just because I did go in kind of with, narrow-minded goals that were very specific to me and my future. So I appreciated being able to talk about a lot of things that I had never thought about, and things that I had thought about, and being able to share my views in a judgment-free zone. And it was definitely interesting to hear different viewpoints from the rest of the class in terms of their experiences, be it at their jobs, be it at their sites. So going forward, I just want to be able to draw back on this experience and say that having had taken this class made a difference, because what I shared at a previous class is that I've always considered myself to be an empathetic person. I've always considered myself to kind of stop and assess the whole situation. But I want to take any time that I'm dealing with someone that may be a difficult patient or, an uncomfortable patient, and I want that to be an opportunity. I want to be able to say, they could have encountered any other person in the pharmacy or any other person in the clinic, and they may or may not have gotten, the time of day that they deserve. They may or may not have gotten the empathy and the time to listen. But when they're going to sit with me or talk to me, they're going to get that. And that's something that, it can be hard. There's those patients that you just don't want to talk to, you don't want to deal with, that suck you into these 20-minute conversations. But that's going to be my goal moving forward, is to consistently be able to do that. And I'm sure there'll be times when I will not be able to live up to my own expectations. But that's definitely what I want to take away and move forward in my practice.
I'm going to make it quick. I know we've spent a lot of time talking. And just even reflecting on being up here, the reason I get flustered, and I'm not usually somebody to get flustered, is that I want to do so much and I feel like I do so little. And that's something that I've reflected upon a lot in this class. And part of the reason why I wanted to get in the class is that I see and I'm inspired by the stories that we got to hear in class of all of you people. This is what I want to do with my career when I finally make it out, when I grow up. I kind of was able to reflect on, where am I at? How do I get involved? What have I done so far, and where do I want to be? And being okay with where I'm at, I don't feel like I've done much yet, but I know what I want to do, and I want to implement this into my pharmacy career. I don't want to just be clock in, clock out retail pharmacist, and so even going into practice, going to be working as a technician, I feel more like an advocate now. I see those populations more readily without having to really think about it. It kind of comes to me, and so even though it might have just been a little step, it was definitely a step in the right direction. Thank you.
Well, I was going to introduce myself, but he kind of did that for me. So I am, just in case you didn't know the face, I am Jennifer, and this is Nichelle. And we got the privilege to work with Park Center this semester. So Park Center is a private I hate saying non-for-profit. I always mess it up. It's a mental health service center that has served thousands of patients each year in the Fort Wayne community for the last 61 years. And it offers a very wide variety of services and opportunities for their patients. They offer services including but not limited to, and I'll show you a list later that I believe is all-inclusive. They include counseling for families, addiction programs, psychological testing, various education opportunities, assistance for homeless patients, residential support, diagnostic services, and therapeutic management. They work with area hospitals as well, specifically Parkview Behavioral Health, to provide optimal care for their patients in the Fort Wayne area. They also have an on-site outpatient psychiatric specialty pharmacy, which is Genoa, that's at the East State address. And this allows the consumers to be able to manage their medications all in one place. So they they might see their physician, but they also can get their prescriptions right there as well. They're currently in process of designing and beginning a new acute crisis center, and this is something the Fort Wayne area really doesn't have and really needs. This would be an avenue for patients if they have a mental health crisis. Instead of having to go and feed through the emergency room, they would be able to go directly to this crisis center. So it would save a lot of money for patients, but also the healthcare system in general, and having to go to the emergency room and then, get assessed and spend all this time and money there, and then end up having to go to Parkview Behavioral. And so this would also take all these steps out, and them having just an acute crisis center. Park Center also has a variety of professional training workshops that they provide to area healthcare professionals, and these are to keep practitioners up to date on the latest evidence-based techniques in the psychiatric field. And I thought this was really cool and really important, and it's different from the patient side of it. It's for us training healthcare professionals. They really want to make sure that everyone's up to date in the psychiatric field, so that you can best help your patients. In Fort Wayne, they have 2 locations, the East State Street, which is the current picture you're seeing, and then the Carew address as well, which is right next to Parkview Main downtown. And Park Center isn't just in Fort Wayne. There's several locations in northeastern Indiana. I don't know if they're... Yeah, there's several different locations, but these were the 2 that we spent time with. The Carew address here will soon also get a Genoa pharmacy as well, so both locations will have the pharmacy, because right now it's currently only at the East State Street location. So I wanted to quickly share their mission with you. I thought it really encompassed kind of my outlook on the psychiatric community. And their mission is to restore lives. They want to really partner with their consumers to strive to support and facilitate their journey toward health, because it's not mental illness, it's mental health, and I'm a big advocate for that. They offer a person-centered treatment philosophy approach as they help those in need to reverse the impact of their mental illness. So this is the list I was talking about of all the services they provide, and I tried to be all-inclusive, because they have a ton of them. As you can see, there's a ton of child and adult services, and then the adult community services, there's a few I wanted to describe because they're not as straightforward, and some that I thought were really neat. The first is the adult residential services. They have a variety of housing options for patients with varying severity of mental illness or mental health related issues. This includes Haven House, Quinn, and Unity House. They have community apartments, and they also have independent living services. So these are all opportunities for patients. They're not just trying to make it on their own in the community. They live with other patients that share maybe very similar disorders, or they could have a wide variety disorders, but they have, it's a community within a community, so they really have that support, and some may receive more help than others. The Eagle Employment Services I thought was really awesome. Park Center works with a lot of their consumers with job skills and job training, interviewing skills, really preparing patients to be able to go out and get a job and support themselves, especially if they're on their journey of trying to become mentally healthy. Being able to provide for yourself is really important because, you have to have money to survive in this world. And one of the really awesome aspects is they own Apple Junction, and it's they make sandwiches, essentially, little sandwich boxes, and I know Manchester's actually purchased, and we've eaten them at some of our lunches. And this food service that they have is run by Park Center and owned by Park Center, and after these patients go through all this job training and they learn all these skills kind of in the classroom setting, they actually have the opportunity to work for Apple Junction. And I think it's like a 6-month period, if I remember right, that they have the opportunity to work for Apple Junction, and so they're learning, the importance of being on time and, working with others and really enhancing their job skills. And most importantly, it gives them the something to put on their resume. So a lot of these patients may not even have a work history. And so, if you have no work history, it's just like, when I was 16, before I went out and got my first job, you have no experience. You have to have someone willing to go out on a limb and be like, okay, I'll give you your first job. And so this gives them that first job and puts them a step in the right direction. The last service I want to talk about is transitional care, and Michelle will talk about this a little more because this is where our big project that we focused on, kind of what we dealt with most. But the transitional care is located at the Carew address, and essentially, it's kind of what it sounds like. It's a transition of care from being in Parkview Behavioral Health, being institutionalized, being in a hospital setting, to being in the community. So instead of just leaving the hospital and then being shoved out in the community, these patients maybe struggle with taking their medications correctly, or just need to learn some skills in order to function properly in society. So they go and they live in it's like one floor, and there's 10 beds or something, and they have roommates, and they have a set schedule, and they kind of learn how to more function in society and with each other, and they have group, and it has aspects of community, but also of what they were used to in a hospital setting. So I also wanted to we wanted to kind of present our goals at the beginning of for the semester for the class in general, but also our experience at Park Center.
Okay, so I decided to take this course because I've worked in pharmacy since I was in high school, and I think I have witnessed a lot of people take advantage of the healthcare system and just programs in general that I think were geared towards the underserved population. And so, unfortunately, I think that kind of manipulated the way I looked at those patients, and I took this class so that I could get a better understanding of this population, so that I could be more empathetic, upon future encounters with them, and so I would know how to recognize them and to know how to interact with them. So that was my purpose in taking the course.
All right, so I took this elective mainly, and I know a lot of my classmates, because I was pretty clear about this, because I took this class because I wanted to be at Park Center. I really wanted to get the chance to work with the psychiatric community, and that is, well, there's two parts to it. The first main part is that I have an interest in a career in psychiatric pharmacy. So I really wanted to start to gain some sort of experience with that, directly with that community, because I haven't had a experience with just that community. I've just had general community pharmacy experience. Secondly, I'm a part of the psychiatric community. I I have generalized anxiety disorder, so psychology and this area of pharmacy or in healthcare in general is very near and dear to me. I'm a big destigmatization advocate. And so that was another reason why I wanted to work with Park Center and to, really dive in and try to get involved. So the first program I want to talk about, this was not our major program. This was what we thought was going to be our major program at the beginning. And it's their ACE program. So what is the ACE program? The ACE program is out of the Carew address as well. And essentially it's for a select group, a population of patients that have really struggled with taking their medications correctly. So some of these patients, it could be a variety of reasons. Maybe they have trouble keeping track of their medications as far as they may be losing their medications. So that's why they're not taking them correctly, or they're just generally confused. So this program really tries to help these patients take the medications on time and in the right dosage, and then all that goes into that. So several of these patients, about 100 or so patients total that they're dealing with. So it's a really small group, but a really important group. A lot of these patients, their insurance pays for these blister packs that this is an example of one, where it maps out each day, what times you're taking your medications, and the pharmacy fills it so it's correct, it's been reviewed, it's all set to go, and all the nurses there have to do is tear off a day or two and hand it to the patient. Because a lot of these patients are coming in like every day or every other day to get their medications. They're not sent home with a month's supply and have at it. They're given a couple days supply or maybe just 1 day supply, so that they can easily more track how they're taking their medications and to ensure that they're taking them correctly. The big issue with this program was the few patients that don't have any insurance or insurance will not pay for these blister packs. So these patients are left with just bottles of prescription medications that most of us are used to. And so the nurses are tasked with trying to organize doses of all their medications, and they would put them in little packs or little envelopes that would signify one dose, and then they would make a label that would have all the information, their patient information, as well as what medications and what descriptions of the medications. So the limitations that were identified with the process and why they asked us to be involved with it was they wanted to make sure that what they were doing was legal, that what they were doing they were allowed to do, and that they were doing it the best way possible. So going into it, we thought, when they first presented it to me, I know my first thought was, this shouldn't be too bad. Well, once you look into the law, law in general sucks. It is so complicated, and I loathe it, and I cannot wait for the law class in the spring. But looking into it, pharmacy law is actually pretty well laid out and pretty specific. It's like, okay, you can do this, you can do that with your labels when it comes to a pharmacist or a technician. When it comes to nurses working with pharmacy stuff and medications, it's a lot more gray. The nursing board is very gray and not very specific, and so that was Sue, which is their head of nursing that we were working with. She knew it was gray, and she didn't know what direction to go. So we were looking into it, and we identified that it was a bigger beast than we could really handle, without misrepresenting ourselves and trying to represent Park Center. So we kind of had to hand that back to them, unfortunately, and their legal team. The other limitation was just looking at the process and safety aspects to see what could we change, or what could we recommend that they could change to make their process safer for their patients and work better. So the recommendations we made for the process, a lot of it were just adding simply double checks into the system. Some of the nurses, there's only 3, there might be 4 nurses total working with these patients. And as you can imagine, if these patients are taking 10 medications a day, they have to do that. They have to organize single doses for these patients that don't get these pill packs. And it takes a lot of time. So they were previously not doing their double checks or having someone double check the labels, which was a big thing. And so now they've started implementing that, or looking into ways that they can start, having the medications themselves double checked to make sure the right drugs are in the right little envelope. And they're using, I think, clear envelopes now instead of the manila envelopes, so they're more easily being able to check, so they don't have to open it and pour it out. They can just look in the clear plastic envelope. And then also the labels, or someone also double checking labels now. So there was some good things that came out of it. I know I was really disappointed at first, because I was like, I really wanted to finish it, and I didn't think that anything really came out of it, but it turned out that there was some good things. So that was a happy moment for me. So I'll turn it over to Nichelle, where she'll talk about our main project.
Okay, so Jen already explained what the TCS program was, and that was just the transition to care, so people leaving Parkview Behavioral and transitioning to the community. So our focus was on the medication administration aspect of that. And so what we did was we set up an appointment to go to Park Center to actually witness the administration process and to see what all that entails. So we got to sit in during an encounter, and basically the patient comes in, multiple times throughout the day, or however many times they have to take their medication, and the staff member goes to the drawer and they pull out their medication box and they give it to the patient, so the patient is able to get whatever medication they're taking at that time of the day. And so we just so happened to witness a lady taking her insulin, and she ever so quickly just drawed it up and shot it right here on the side of her arm and just whipped it out really quick. And so immediately we just saw so many things wrong with with what she was doing. So we immediately saw where we could jump in and how we could help. So these were the main aspects of our project, and I'm going to go into detail about each in particular one. So the first one is the medication management competency checklist. And so what this checklist is each staff member, most of them have no type of medical background or any type of formal medical training. So this checklist is provided for them. They have to do this before they're able to, start working their position, and they have to go through a series of things. And this is just the first page. I think it is 2 pages long. And so the first one is, let me read it from here. The staff on duty is responsible for ensuring that client self-administers the correct medication as prescribed at the correct time, in the correct dose, and by the correct route. So they have to be able to perform just all these tasks, to ensure that they're able to do this job, and to ensure that they're able to actually watch the patients as they do this. And then the other page that I wasn't able to put on here, it has a list of things where, if this happens, call the doctor. And we had a meeting that I was not able to attend, but Jen was, and one of the questions that came up in the meeting was, do you know what EPS is? And a lot of the patients had no idea what that was. So that brings me to my next point, and this was something else that we worked on. So we were not able to provide them with a formal document that said, this is what EPS is, because we weren't able to find one. And so for, again, legality issues, we didn't want to make anything or be responsible for that. So we looked up some primary literature, and we were able to find, just the basic signs of EPS so that the staff could be aware, because they weren't. And so to know when, this is what it looks like, and so if you see this, then you should call their physician. So we were able to gather some information, and we kind of just handed it to them, in no formal way, or, so they were able to format it themselves. And here is a picture that we provided for them, just to see, kind of get a feel of what it looks like, and just the Parkinsonian. And then this is a document that kind of pinpoints things that are specific to tardive dyskinesia. So just some things to look out for in regards to that, because the staff, again, they have no medical training, so they had no idea what this was or what to look for. And so we also have a video that we're going to show very briefly, and it shows some of the visual things to look for in these type of patients if they were to ever have this type of reaction. So we're going to very briefly show.
In the second segment, notice this patient's...
How do I drag it over to like, what do I grab? Up there?
Top of the bar and...
Oh, up there. Okay, nice.
You can expand.
Okay, cool. Okay. All right. And these, like, all these things are things that these are examples of things that we provided to them. So they have these links to these videos.
Thinking. Try not to be distracted by the other facial movements.
So they're kind of like educational, like, pointing out the specific...
Notice the blinking takes place during the finger tapping exercise. This is one of the activated movements. The 1-point score reduction used by some examiners is not recommended.
You can X out that
Example of why a point should not be subtracted when scoring movements detected during an activating exercise.
I don't know what you did. So
I don't either.
I don't even know where it went.
Segment 11 is quite short and will be shown 3 times. Notice the increased frequency and amplitude of this woman's jaw movements compared to the previous segment.
Okay, so like Jen said, these were extreme cases, but we still just wanted to kind of give them something to go off of or something to, to look for in their patients. So as I said earlier about the insulin story with the lady who just shoved it in real quick and pulled it out, that was obviously very incorrect. So we also, so we also provided them some information on proper technique just so they can be aware and kind of guide the patients. Because they don't have any true medical background, they can't administer the medications for the patients, so the patients have to do it themselves. And so we wanted the staff to be equipped with the knowledge to guide them. So, we just gave them something that has the proper sites, and as you can see, the site that the lady injected in was not correct, and when she checked her blood glucose, it was well over 200. And so we wanted to make sure that they had this. And the final portion of the project that we worked on was asthma inhaler use. So many of the staff expressed us that they were not aware of which inhalers they could use for acutely or which ones were for maintenance. And as most of us know, that if in the event of an asthma attack, it's very important that they use that acute inhaler, because if they use the maintenance, it won't work in time, and that could lead to more serious complications. So we wanted to provide them with some documents that they could post in the room where the medication administration is taking place, just so the staff can see and just so the patients themselves can have that reference to look off, just to make sure that they're using the proper inhaler at the proper time. And so that was the end of our project that we worked on. And so as far as reflections, coming into the class, kind of like what Misty said, I kind of had the mindset that I was going to work with, directly with patients. And I knew from the start that I wanted to go to Park Center. And in my mind, I said, okay, Nichelle, you're going to go to Park Center and you're going to help every patient, and it's just going to be great. And very quickly that was shut down. So as you can tell from the project that we had, we didn't even have any direct interaction with any patient, and the one. But so once I kind of got over that, I was able to really look at the bigger picture and to realize that what we actually did was bigger than what we could have done in the little 13 weeks that we had. And it kind of had a ripple effect, because, with the competency checklist, like every staff member that comes there, they have to go through that checklist. And, we help to kind of manipulate that to make it more convenient for them, and, to add some extra things that we felt was necessary. And even, so every staff member that comes through there, they're going to be the ones that directly help those patients. And so, we can say that we help them and they helped everyone else. So it kind of has a ripple effect. And so I think that was the biggest point for me. And I mean, I enjoyed the class too. As you can ask anybody, I was the most quiet person in there, and I very rarely talked. But I had expressed to everybody like the last week that I can admit that I'm kind of narrow-minded when it comes to topics like this. So I like to just listen to other people and just get other people's perspectives on things, because it just opens my mind to things that I would have never even thought about. So I enjoyed that, the discussion part of the classroom, even though I didn't partake in much of it.
All right, so my reflection at first for the class, I mean, anyone that knows me knows that I could talk someone's leg off probably 3 times. And so I loved that it was a discussion-based class, and it was, since it was just so few of us, we really all pretty much spoke our minds, except for Nichelle, who barely spoke at all, but that's okay. And so it was a really enjoyable class, and Dr. Hansen and Dr. A are very open and honest about in general anyway. So it was definitely a no judgment zone, and so that was a really awesome aspect, and really an experience that you won't get, or we don't get in any other class. So I agree, it should be mandatory. For working, my opportunity at Park Center, I really obviously enjoyed being able to have an impact with the psychiatric community. I'm a person that, once I start something, I really wish I like getting things done and seeing an end product. So I had to get over that pretty quickly, that, I couldn't, solve everyone's problems quickly. So after I got past that frustration, and then at the end, talking to Sue and Kristen and Rich, and them expressing their gratitude, and, really what our projects and what we worked on, what impact it really had for them. And that was really exciting, because it was a happy moment, because it was like, oh, I did make a difference. So in general, it was really empowering for me to serve a community that I'm a member of. And as I have stated a couple times, I have an interest in serving the psychiatric community in my career, and it has a lot to do with the fact that I can personally relate with those in that community and their daily struggles. It was a privilege to get to work with Park Center and make positive changes that will continue to help my community in the future. And I want to leave you with a quote that I found that really spoke to me about the meaning of service. And I also shared on the blog that we keep, so it might sound familiar because I know you chronically look at that blog. It states, "Your gifts are not about you, leadership is not about you, your purpose is not about you. A life of significance is about serving those who need your gifts, your leadership, and your purpose." Thank you.
Okay, so the local organization that I chose was the St. Joseph Community Health Foundation. And I went ahead and put their mission statement up there because it's something that both Meg and Marla, who were here, kind of emphasized to me. And the foundation was founded by a woman by the name of Mary Catherine Casper, and she also founded a Catholic order known as the Poor Handmaids of Jesus Christ. And that order actually now sponsors different ministries all over the world. So, let's see. The people in charge are Meg Disler and Marla Rust, and Meg is the executive director, and Marla is the executive assistant and grants coordinator. So just a little bit about what the grant process is. They took me step by step through. My biggest question was, do you turn a lot of people down? People think grants, oh, free money, let's just go in there, everybody gets it. And I guess they don't actually have to turn a lot of people down, because it's a collaborative process, and they encourage each organization who does want to need help funding to call and work with them together. So it's pretty easy. And they have 4 core values that they follow. And again, this is something that both of them separately emphasized to me. Openness to the Spirit. They believe in responding to the needs of the time. Community. They believe in attentive listening and with a courageous response. Simplicity, we believe in the wise use and care for all resources, and dignity and respect for all. So they believe that all human life is sacred. Each person deserves the right for respect, regardless of race or circumstance. And each person has rights and responsibilities and must be respected and treated fairly. And since 1998, the St. Joseph Community Health Foundation has served the poor by funding programs that improve the health and wellness in Allen County. So these are some of the organizations they fund, and I'm sure you heard about, or well, I think they did, well, they do Matthew 25 too. I didn't guess I put that up there, but so the foundation contributes approximately $1,300,000 per year to improve access of the health and the poor and vulnerable of Allen County. And to date, the foundation has invested over $15.7 million through 1,022 grants to 182 local agencies that provide low cost or free health care. And in addition to providing grants to these area organizations, the foundation also operates programs to fill gaps in service to strengthen the long-term health of Allen County. And so Meg and Marla were kind enough to let me reach out to one of these organizations and help them more. So we decided together on choosing an organization called Remedy Live. And it's an online text-based ministry that's marketed toward teenagers and young adults. And in their world, and I guess everybody now, this group of people is known as millennials, so they refer to that a lot. And it was launched in 2007, and they have over 880,000 visitors annually to the site. And of those 80,000, 1 in 3 teens that contact them are texting them through dysfunctional homes or struggling with addiction or suffering from a crisis, and a lot of times they're depressed and considering suicide quite often. And the individuals that are in a crisis and considering suicide might not really have an outlet. They might not have family to turn to. They might not have a friend that they want to talk to at the risk of being judged. They don't want to be looked at as the person that's going through all those problems. And that age is a really delicate age as it is, and if they're going through so much, I know it can be really hard to talk to someone. So it would make it even harder to talk to. Remedy Live is essential for those individuals. Text is all it takes to get started, and that person is instantly connected to what's called a soul medic. And these trained soul medics are like counselors, so they promote a non-judgmental style of listening with allowing open dialogue back and forth. So the executive director of Remedy Live is a man by the name of Clinton Falpel, and I worked with him. He kind of is a guy. He has a lot of great ideas, and he wants to do everything, but he can only do so much. So one of the things I asked while we were working together is, because he kept kind of throwing around the term soul medic, and I didn't really have an understanding of what it was. And my biggest thing is okay, so you get the teenager, they want to reach out, they want to talk to you, but what's going to make them really open up to essentially a stranger? And he said that a lot of times, these people do want to talk, and they probably don't want to commit suicide if they're wanting someone to talk to. So he figured that a lot of people would have the same questions as I did about what a soul medic is. So he decided to film a video. They're really into media, with it being a younger, generation. And I was lucky enough to be a part of a video. So the first one, not the second one.
Okay, I'll show the first one. Right. I'm going to take a quick peek into my Facebook page because it is on Facebook.
To us at all times, creating isolation that oftentimes can paralyze our core desire to be understood and feel significant in the world we live. So at Remedy Live, we didn't want to be just another courier of information or feel-good website with cool videos. We wanted to engage those searching for support in a conversation that meant something. And in order to do that, we needed people that cared deeply for the hurting and the hopeless that were searching the web for answers. A soul medic is more than just a warm body who volunteers an hour to have a chat conversation. They're people of deep compassion who have committed to engage each chat client with a simple and yet profound question: how are you? Through listening, the soul medic provides a safe place for the client to share the depth of their struggle, so that a bridge of trust can be built between the soul medic and the client. And through trust, courage is mustered, hope is instilled, and the client is challenged to live a life on purpose and not by accident. These amazing people are reinventing the role of the missionary and embracing the internet and technology as the new mission field, since that's where most of the millennial generation spends their time. Through the commitment of the soul medics, Remedy Live is able to provide 24/7 staff support to our chat center and provide a place for the hurting to know they're not alone.
So that was one of the videos I was in. Okay, and so then we also put together another video to make people aware of some of the trends in societies and the struggles surrounding suicide and mental illness, because another goal of Remedy is they want to remove the negative stigma surrounding someone who's mentally ill. And so the next video is put up on their website as well as page, and it gets more people talking about Soul Remedy, and as well as reaching those who are in need of someone to talk to.
Adults today, the world seems overwhelming. Millennials text what they want, do what they want, say what they want, without really thinking about how it affects others around them. And if you look at the trends over the past 50 years and see the correlation between the breakdown of the family and teen depression, or the advances in technology combined with loneliness and isolation, one can see the formation of a major problem for this generation. Do we know what it means to hope? This generation has grown up in a world based in terrorism and the fear that it causes. We've grown up never not knowing access to Google and all kinds of competing opinions. And the fastest growing faith among millennials is the belief that nothing exists, that there is no higher power, no savior, no hope bigger than my circumstance. So when I look at my generation and I see their struggles and then see the trends of hopelessness and disbelief combined with escapism and experimentation to find happiness, I can get discouraged about what the future holds. So many in my generation are holding on to secret struggles that are taking over their ability to live their one and only life to the full. And even though we're the most wired generation ever in the history of the human race, we seem like the most isolated and disconnected from true, honest community. Has the golden rule been replaced by the survival of the fittest? Rather than to care and love others, we've protected ourselves from the world so it doesn't hurt us anymore, ultimately becoming less trusting, more selfish, and further isolated. Well, before I depress you any further, I do want to tell you about an exciting web-based organization that is really making a difference in the lives of youth. Remedy Live recognized that millennials were far more likely to open up about their struggles if they were met on a medium that was safe, comfortable, and familiar. So, for the past 8 years, Remedy Live has been building an online team of listeners called Soul Medics, developing software that turns a text message into an anonymous conversation, and working with Google.com so that a search around a struggle can start a meaningful conversation. We're simply asking, how are you, can really get to the bottom of that question. Hope is being invested into thousands of lives each year, and courage is being placed into millennials to get them to talk to someone face-to-face about what's keeping them in isolation and pain. At Remedy, one person an hour is sharing their struggle with suicide, and through chatting online with a soul medic is leaving the chat just 35 minutes later feeling like they're not alone, and the confession of their struggle was the first step to health and wholeness. I am, part of a great generation. Millennials are incredibly creative and innovative, and we will change the world. But an increase in mental illness, combined with a decrease in spiritual wholeness, has posed a unique challenge. We must do whatever we can to engage people in a conversation that allows them to share their struggle, so that the love of God can cover them and provide hope to live their life differently. I'm so excited to be a part of what Remedy Live is doing and spreading hope to those in need. To learn more about Remedy Live, visit the website at remedylive.com or simply text the word CARE to 313131.
Now, hold on. This was posted 24 hours ago. It already has 1.3 thousand, so 1,300 views in the span of 24 hours. So I have to point that out.
And so I feel like this organization directly embodies what the St. Joseph Foundation was set up to do, and that's to provide hope to those that are hopeless. So, going into this, I took this class because I like to help people. I like to do service. I like to, help those that are underserved, I guess you would say. And But me personally, I just need a push sometimes in the right direction. Like I can say I want to volunteer all day, but when it comes down to it, I almost need like someone to help me get there. And I knew based on last year's class that they really were able to help out and make a difference, and that's something that I wanted to do. And so choosing this organization, you know, I was really interested in the grants process, and then after I chose it, I kind of was thinking, well, wait, how am I going to have an impact based on what I chose? And it doesn't seem pharmacy related at all. So I went back and forth, and you know, Dr. A and Dr. Hansen kept telling me, you know, it's okay if it's not pharmacy related. That's not the only goal of this. And so, you know, they put my mind at ease each week. You know, I was pretty concerned about it. And then even getting together with Meg and Marla, even they were very enthusiastic about it. And so it helped me, it just helped me feel better about it. And then meeting with Clinton, and it just opened up all these new doors. And then while filming this project, actually, I have my great aunt actually committed suicide. And it threw, you know, everyone in the family. No one expected it. And I've been touched, you know, my whole life with mental illness, and just with people in my family, and being able to really help out this program, you know, for young people to, because in my opinion, if you start young, it will only help you in the future to know that you need help. So, and being able to prevent suicide and just help people further in their life is something that is really important to me. So I'm glad that I got to do this, and I didn't expect that I was going to have this impact or it was going to mean this much to me by any means, and it really was surprising to me that it did. So I'm really glad. And let's see. And again, with, you know, I think what Miss Sue was saying and some other people were saying about the classes is I got more out of this class than some of my, you know, the actual pharmacy-related courses about the medications and everything. So, yeah, and being in a position to help others even now is great, because I know even going further that I'll be able to do so much more. I know Dr. A is on a whole bunch of different boards, and yeah, it's just it gives me a really great feeling to be able to, you know, help other people. So that's all.
Okay, so this is our blog, and this is, you know, Kirsten and I every now and again put a blog up. I just wanted to put this one up here. This was the last class, and I'd asked the students to write one sentence to sum up their experience in the whole semester. So we got this class should be mandatory. We heard that. Your grades are in okay already, so it's okay. No one can save the world, but if you can help just one person, that's more than enough. This class has opened my eyes to the challenges some people face. The concept of hope in a bottle, that I guess I missed that discussion in one class, but symbolic enough. I know it was like everybody refers to that class, and it's the class that I missed. Selflessness for the greater good of mankind. There is no act of kindness that is too small. Abide in faith, hope, and love. The greatest of these is love, and service can only be measured in love and what you do for the least. So it's something that Kirsten and I have shared with the class. Kind of, it's not in the middle of the semester. We usually get this point of, I don't know what the heck I'm doing. I can't get anything done. I can't save the world. I don't know my project. But what we shared with them is, you are the project. I mean, the project is not what you've done for these sites. They definitely appreciate what you have done for them, and you've definitely offered them something that they probably wouldn't have had the chance to look at. Like, you know, Dr. Spister mentioned, a lot of times we research, we publish on things that don't work just so that we know not to repeat it. Other little impact that you may consider as little has a huge impact on the organization and the people you served. And just the fact that you showed up, took 2 hours of your busy third-year life as a pharmacy student, that shows a lot about you and your character to these organizations. But you are the project. The project is when you walk out of this program or this class that you're going to do more than just work for a living, and you'll impact the community, whatever community that you live in, whatever community that you choose to impact. So, and for Kirsten and I, we're projects as well, because we're just always amazed by what you guys can do, the creativity, the growth. I wish I had a camera and I just videotaped you the whole entire time. The growth from the first day you walked in to the last day that you wrote this. So thank you for a great experience. Thank you to our partner organizations for giving us the time of day, for allowing our students to come in and learn. Experiential learning obviously is a passion of mine, and just to have the ability to have partners in the community that we can send students to is fantastic. I mean, it's undescribable. So if you had last or final thoughts that you'd like to share with the students, please do. Brad or Rich, I don't know if you had anything to share with us about students.
What you said, our appreciation for the ripple effects, that is very true. People don't realize what they start and how long it
Thank you. And
I was going to be much more mercenary and say that volunteer organizations exist only on the unpaid labor of students and other send it in to us.
I certainly will. And I'm hoping that by next year we can get around to offering it year-round, not just in the fall. But this is only our second class, and wanted to test it out.
Congratulations to both of you. See you